presenters, as I said, there's Manohar and the time assigned is 35 minutes.
Please introduce yourself.
President from Sri Jayadeva Institute of Cardiovascular.
I'm Dr. Kumaravel, final year PG from Chengalpattu Medical College.
Yeah, you may start. So this is a short case. So what I was told is that first you will give a brief history and details of your clinical examination. So brief history now.
Yes. Sir, my patient is of a 49 years old female patient who came from Markaspur, came with chief complaints of, had predominant complaints were breathlessness of NHA class 2 since 2 years. And there is a 1 month ago, she had a sudden onset of cough along with a chest pain, and she admitted in a local hospital where they were evaluated, and she has been prescribed medication followed by her symptoms were subsided. And the chest pain is of typical anginal type of, which was of a retrosternal, and which was a chest pain, and it's like of more of an sudden onset chest pain, and it was been relieved with the medication which is given in the hospital, and she needed an emergency hospitalization at that time. Yes, sir. A 14 years old male patient came with the chief complaints of breathlessness of NHA class 2 since 2 years, with a sudden onset of chest pain 1 month ago, and which made her hospitalization, and the pain relieved followed by medication, and the pain characterized of a typical anginal pain. And present her, she was in NHA class 2, she restricted her activities, and she was on oral medication.
Do you think the chest pain is suggestive of angina? Typical or atypical or non-anginal?
Typical anginal pain, sir.
How do you say
Says
that?
The pain was of more of a retrosternal, and the pain was at that time she was sudden in onset, and it was radiating to the left arm.
What are the three criteria to say it's a typical angina?
Sir?
3 points to say that
character, site, aggravating and relieving factors.
That is asking about 3 classical features to describe typical, atypical, and non-cardiac.
Character of the pain, site, and aggravating and relieving factors.
So site agreed. Then the second point is
character of the.
Okay. So when do you say typical angina? When do you say atypical angina? When do you say non-anginal chest pain?
Sir, these 3 features of the.
All the 3 are there in this typical. What are the 3 features? One site is they agreed. What else?
Aggravating, second factor, third factor, relieving factor.
It should be on exertion. Was it on exertion?
No, sir. She had a sudden onset associated with the drenching sweats and all, and followed by she was.
So what should be your answer to sir's question is most of these 3 features are for chronic stable angina.
Yes,
They are exertional angina.
Exertional.
So if you use this classification, all your unstable angina MI will be atypical.
Yes.
So we cannot use this classification there. It has to be only exertional chest pain, then you can use this. But is it MI? Are we dealing with a case of MI?
Sir, what she was given of any history was.
What are the typical angina and what is the difference between typical angina and MI chest pain? Like a classical MI.
So sudden in onset.
Both will be sudden in onset. Okay.
Severity and duration?
Sir, duration
and severity.
Severity, duration, and associated factors. So what are the typical duration of an MI chest pain?
As the time progresses, the
pain will reduce.
Severity of pain increases.
No, but what is the duration of chest pain in an MI compared to an anginal episode? In an MI, acute MI, what is the duration of chest pain?
More than 30 minutes.
Generally, it is more prolonged. Whereas an anginal episode generally short. So less than 10 minutes in general. So what about associated factors like?
The sweating with the sympathetic activity stimulations like
Sweating,
taking,
vomiting,
vomiting, and giddiness.
What are the other conditions which produce anginal type of chest pain without, apart from the myocardial?
Sir, non-atherosclerotic causes of CAD in aortic stenosis, there is a supply-demand mismatch. In ischemia of RV ischemia, if it is of IPH, pulmonary artery hypertension, or sir, HOCM with myocardial bridging type.
So no,
What are the other structural heart disease?
Aortic
Can cause
dissection.
anginal extension.
Aortic
Aortic
dissection, which is of typical of backside pain. And
so this 14-year-old female patient has come with breathlessness on exertion for 2 or 3 years and
Yes.
then sudden onset retrosternal chest pain. So how do you approach this symptomatology?
sir, whatever the patient is having an established cardiac heart disease, if based on the history for 2 years, and one precipitating factor has aggravated her on the day of admission, which made her hospitalized on the day. Like,
So what are the possible cardiac causes for an exertional breathlessness in a middle-aged female? Assuming it's a cardiac disease, what could be the possibilities?
sir, most of the physiological things like anemia could be.
You said, assuming it's cardiac.
Okay,
So leave alone non-cardiac and other medical conditions. So what are the cardiac causes of dyspnea and exertion in a 14-year-old female?
Sir, most
some
common
chest pain.
valvular heart disease of the left side, like mitral stenosis, could be there. Of an LVOT obstruction.
How do you explain retrosternal chest pain in mitral stenosis?
Sir, PH causing the RV ischemia.
How often do you see that in an MS patient? So theoretically it can. How often?
Percentage like this, like sudden onset chest pain. How often you say? Almost never.
So now this leads to the question, do you attach any importance to that retrosternal chest pain as a part of the symptoms of the cardiac lesion, or is it unrelated to that? That also is another question you have to consider. Okay, because if you are unable to fit that into your overall approach to the problem, then you might like to disregard that. Okay, one is mitral stenosis you want to consider. So what is in favor of mitral stenosis and against mitral stenosis with this?
Sir, there is no PND or orthopnea episodes which is saying of no palpitations history which not there.
But it is there, it would maybe consideration of MS will be much more stronger, but the absence doesn't exclude the
Sir,
consideration.
Preload condition like fatigue and all.
Why do you expect fatigue in an MS patient? When does the patient with mitral stenosis get fatigue or exertional fatigue?
Once the pH get established.
When the patient goes into low output state due to right heart failure, there is an advanced state of mitral stenosis. Otherwise, the fatigue is not an important symptom of mitral stenosis. Okay. Still okay. In India, you might try to consider mitral stenosis. Anything else?
Leave alone your exam. Suppose if you are sitting in the OPD, a 50-year-old female comes with chest pain, predominantly chest pain and some dyspnea before. Do you want to keep MS as your first possibility?
No, sir.
So why do the part of the other possible? That's what I is asking. Be realistic also.
CAD, coronary artery disease.
Why dyspnea and CAD?
Sir?
Why dyspnea and CAD?
Angina equivalent symptoms.
One. What are the other causes of dyspnea and CAD?
Sir, establish LV diastolic dysfunction.
Or
Sir,
systolic dysfunction. What is
Systolic.
systolic?
Ischemic cardiomyopathy?
Ischemic cardiomyopathy.
Then what else? One, whenever there is ischemia happens, diastolic dysfunction happens, the patient can have heart failure. Okay, what else? What about ischemic MR?
Sir, it will be the sudden in onset with a 2 to 4 days history of post-MI.
No, one is post.
Not necessary.
Yes,
That is different.
No,
That
so
is
you're
separate
saying
from the
LV
dysfunction.
dysfunction.
Ischemic MR is not post-MI MR.
Yes, sir.
Always.
Yes, sir.
Okay.
MR.
The transient ischemia causing transient MR can also happen. Okay. So what are the sequence of events that happen when the patient develops ischemia? Sequence of events.
Diastolic function.
So diastolic dysfunction followed
It's
by
already giving you a hint.
So the first thing is of a progressive event like if a diastolic dysfunction followed by systolic dysfunction and the patient's just of a so percent of the myocardium involved if it is more
No,
than
no, no, we are not asking about that. So diastolic dysfunction first agreed, then systolic, then what will happen to filling pressures? Elevation of filling
elevated
pressures.
will be
Then ECG changes, then angina. You understand that? So angina is the last thing to occur after the ischemia occurs. Okay, anything else you want to consider? At least 3 differential diagnoses you give briefly, then we'll move on to the examination.
Sir, in this elderly, this mitral valve prolapse with MR could be.
If you are thinking of previous angina, then give the differentials of angina first. If you are thinking of atypical chest pain, then you think of MVP and various other things, and all those things. But if you are clearly categorical that this is anginal chest pain, retrosternal pain, then give those things first.
That's what I first told you. So how do you want to treat that chest pain? Do you want to give importance to it or do you want to ignore it?
Sir, the chest pain was exhibited with the cough and breathlessness. So it could be an misleading factor for me.
Can this be IPH?
Sir?
Can this be IPH?
Sir, IPH, the
3-year
patient.
dyspnea, 14-year-old female comes to you now with chest pain and worsening dyspnea with some chest pain.
Sir, but there is no progress history of fatigue or patient low cardiac output state from the last 2 years.
And you expect all the IPH to behave like that. 3 years is not a big time in IPH. Can this be DPH, IPH?
No, why do you want fatigue to be an important symptom in every lesion? That's what you said, even in mitral stenosis, fatigue. So don't be obsessed with one particular symptom. And sir is suggesting in a female patient, middle-aged, presenting with some 3-4 years of breathlessness on exertion, with no history of orthopnea or PND, ruling out perhaps a left heart, significant left heart disease, you might as well consider a right heart disease like a pulmonary hypertension.
Angina is significant, you want to keep HOT as a possibility.
Sir, there is no family history suggested of any.
Okay, then you tell what do you want to consider?
Palpitations.
You see, whatever suggestions we are offering to you, you are negating. So no, to tell us what do you want to consider? One is mitral stenosis, he said, with a little pinch of salt, we have accepted that. What I want 2 more differential diagnoses.
The pH could be.
That's what I'm suggesting. You negated it and now you want to.
PAH syndrome, it could be idiopathic or something else. Okay, PAH syndrome, right?
So
then
ischemic heart disease, you should keep first in a 50 years old in India today. Ischemic heart disease, possibly before even MS. If you think that is serious angina, and that episode is a classical pain lasted for 20 minutes, 30 minutes.
no, just give on your own one differential diagnosis, which is convincing here. Sir is not going to suggest. You may suggest. Kumarvelu, huh? What is your name?
So oftentimes you must be wondering why we are all repeatedly banking on this. Like, what is the importance of this? Is we are trying to understand whether you understand the natural history of all this and whether you are able to apply it in a particular given. That is the primary purpose of a clinician. Whatever you do, whether you are able to apply the knowledge that you have.
Could you consider dilated cardiomyopathy with this history? It's not necessary always that they should have presented with, frank heart failure. Huh? In early stages, where there is no LV dilatation with some LV dysfunction, there can be exertional breathlessness only without right heart failure or no biventricular failure. So you might consider that early stages of dilated cardiomyopathy. Sir. So summarizing the historical considerations, mitral stenosis, sir has suggested ischemic cardiomyopathy, pulmonary hypertension, and dilated cardiomyopathy.
And
HOC.
There's nothing against HOC in that.
Restrictive cardiomyopathy would you consider?
Sir, there are no predominant right heart failure symptoms, patient presentation.
So what is predominant involvement, incidence of predominant involvement of left heart in
LV filling pressures, which is causing of this.
and what is the incidence? Left heart alone is involved in endomyocardial fibrosis. Left heart involvement, right heart involvement, biventricular involvement. What is the relative incidences in India?
Predominantly the right sided disease or left sided disease? Or biventricular?
Cardiomyopathy. Restrictive.
Restrictive endomyocardial fibrosis we are talking about.
Prominently, RV type is more, right ventricular type is more common than left ventricular.
Biventricular, right ventricular type is more
More
common.
common.
Biventricular is more
Right ventricular
common.
type is
Okay. Go to the exam.
Sir,
salient findings in the exam.
yes. Sir, on physical examination, the patient is conscious, coherent, well-oriented, and the pulse rate was 80 per minute. The blood pressure of the right upper limb and lower limbs were 120 by 90. And the sir, pulse is regular, sir, normal volume, no radioradial delay. Sorry, sir, there is a radioradial delay, and there is no radiofemoral delay, and the saturation of the right upper limb was 88.
You have a relief, what is there? What are the other pulses?
Sir, no radiofemoral delay was appreciated from. Yes.
Is more well
Sir, left radial is more well palpable, sir.
What is the BP difference? Just say 21 blood pressure.
Sir,
You have a radial delay. You have to give all the four blood pressure.
sir, yes, sir. We are giving the right upper limb brachial artery pulse pressures were 120/90. On the left, it is 120/80, which was.
Where is the question of delay then?
Sir?
So when do you get delay? Is can delay occur in isolation without any effect on the volume or strength of the pulse?
Sir, it's like more of an iatrogenic cause in the hospital because the no, sir, but the pulse when compared to other pulse is very few.
What about right brachial?
Brachial is good, sir. Right brachial is good.
Because once you say radial delay, then we think of some other disease. You're undergone a procedure also.
He was not giving an history, sir, but they're taking some samples were taken from this and could be an ABG.
Okay, continue.
Sir, the saturation of the right upper limb, it was 88%, sir, on room 8. Yes, sir.
Left also.
Left is also same.
All the four limbs are 18%.
Yes.
Addressed.
Yes, sir.
Exercise?
No. Lower limb, sir, will know 90 it is coming, sir. Sir. The remaining, there is no clubbing or cyanosis or palar or ictus were appreciated, sir.
No clubbing or cyanosis.
So no, sir, we can't develop shape.
Is there exertional cyanosis occurring?
Sir, we didn't made her exertion, sir.
You didn't make.
We didn't.
Would you have done? Would you have liked to do?
Sir, resting saturation was 88%. So by exercise.
Then why is she not cyanosed? So what is an early sign of cyanosis? Intermittent right to left shunt, let us say, assuming it's a right to left shunt across a shunt lesion. If there is no frank cyanosis and saturation is something like that, what would you look for very meticulously? That's called as a tuft erythema in the fingernails. So tuft erythema suggests intermittent right to left shunt occurring. Okay.
And sir, in general physical examination, only we can appreciate this much, sir. On can I go to the systemic examination? General physical, yes. On systemic examination, inspection and palpation, the apical impulse is not. Sorry, sir. Sir, JVP, there is normal way, JVP, sir, with a normal waveforms were visualized. Sir, it was on sitting, it was not seen. So it looks like
No, do you look for the JVP mean column always in a sitting up position? Or?
Sir, if in sitting, if the JVP is visualized, it implies that it's an elevated JVP. Then I can make it on a 45 degrees and to measure the JVP.
I think it's a little convoluted way of looking at the JVP. You try to do in a systematic way as traditionally it is recommended or advised. So let the patient recline, keep the patient in a recline in 45 degrees and then look for the JVP. If 45 degrees recline, if you are not able to see the upper column, then you make the patient sit up and see for the upper column. Okay.
What about the waveform? How do you look at the waveform? Even at 43, you're not able to see the waveform. Then how did you look at the waveform in this particular? That's what you're saying. 43 also it is not see the waveform. So how did you think that this waveforms are normal? May have died out?
Line.
So then can you tell what is the limit of the column? What is the height of the GVP? You are able to see lying down.
Yes, sir, we can see, but it's more like of a normal waveforms looks like, so there's no problem.
Somewhere it is seen, so can you report the height?
Sir, it was around the mid of the stairs.
Don't get into the trap. So you cannot
Comment on
on the height of the GVP when the patient is made to lie down flat. So it is one column, one straight column. You cannot measure the height. So it can be used to diagnose the waveforms of JVP, identify the waveforms of JVP, but it cannot report the height of JVP when the patient is made to lie down flat. Same thing like apical impulse, if you are not finding it, can make the patient to left at the position, find the character of apical impulse, but you cannot use it for the position of apical impulse. These are the basic things.
So please again, clearly tell your examination findings of JVP.
Sir?
JVP, please tell again.
Sir, the JVP was normal, sir, with normal waveforms were visualized and which were
Whenever you speak of JVP, there are two components
Sir,
to JVP. One is the mean column height or pressure component. P means pressure, as well as pulse amplitude or pulse wave pattern. So you should tell about both. How is the JVP mean column height, which you said in straight 90 degrees upright position, it is normal. It's okay. Then how is the waveform? It is normal. Normal means A is more than V. A is normally more than V, is abnormally more.
like normal more than is not an abnormal wave, A wave type of.
It is not a giant A wave.
Don't get into the solve trap. The struck only is right, take it to case that JVP is not important. So remember, if you are able to tell JVP in fashion like normal waveform, the height of JVP and respiratory relation, generally you will have moved out. One.
Sir, on inspection and palpation on the cardiovascular system examination, sir, the apical impulse is of not well localized. On left lateral position, we can't able to see, characterize the apical impulse. It is more type of an RV apical impulse, sir. And then there are no associated thrills, but there is a grade 2 parasternal heave was appreciated, sir. And there is a palpable P2 on the second intercostal space. Grade 2 parasternal heave with palpable P2. So on epigastric pulsations, the RV pulsations can be felt, sir, at the tip of my thumb, which is of more of an RV pulsations. No thrills. No thrills.
How do you know it is RV apex? Why is it not an LV apex?
Sir, it is not well localized, characterized, and the second thing, the heave, whatever I felt, it's somewhat synchronizing with the apex on the side, sir.
Maybe that we would have discussed all this, but there's been 3-4 points for an RV of LV impulse.
Sir,
what are those
it's a localized of a LV with a medial retraction. It will be in LV.
That's a very important thing that we should.
Medial retraction, and
You will have lateral retraction if it is in a RV apex. Diffuse in nature. So if you have RV enlargement suggested by left parasternal pulsations and also a localized LV impulse at the apex, what else will be there?
RV.
You have an RV enlargement suggested by left parasternal, not in this patient, left parasternal pulsation, and an LV impulse in the apex. What will be there between the two? There will be a
LA pulsation.
LV. Apical LV pulsation and left parasternal pulsations of RV. You will have a retraction between the two.
Retraction.
So in other words, for the sake of everybody, like how to differentiate between LV and RV, LV effect is generally very localized. It's a ping-pong ball coming in between two ribs. Whereas RV effect is generally a diffuse apical impulse covering more than two, and then medial versus lateral retraction is there, and then most important thing is that I think we just become cardiologist, we just forgot undergraduate. First and foremost point is lateral versus down and out.
Down and out. Okay.
LV is down and out, whereas RV will be lateral distal. That should be your first point. The fourth point is whether it is continuous with your
Parasternal.
These are the 4 points generally considered between LV and RV kilometers.
Okay.
So that's sir, percussion, the second space of the left side is dull, sir, dull now, and the cardiac borders were local.
Here, I think infantile permission is important. In this case, is important because there is synovitis. Whether it is situs, solidus or not.
Yes, situs was normal. Sir.
Start with that. Okay. Situs, liver, and then go to the one.
Sir, on all. Sir, dulls. Sir, on auscultation, the S1 was well heard. S2, there is a wide split. S1 is normal.
S1 is normal.
Normal.
S2 is?
S2 is wide split was there heard, sir. Wide fixed split is there.
Wide fixed split.
Yes. With an P2 component of the split was loud, sir.
Loud means is it more than A2?
Yes, sir, it's more than A2.
It's more than A2 given at apex?
Yes, sir.
Very important.
Yes.
Why is it important?
Sir, in pulmonary artery hypertension.
Yeah, I know. So how do you grade clinically the severity of pulmonary artery hypertension based on the relative intensity of A2 and P2?
Sir, if the P2 was loud, it's okay, and palpable, the pulmonary artery systolic pressures will be more than 50, is one of the proved findings.
No, my question is about relative intensity of A2 and P2.
Sir, generally the P2 will not be heard at the apex. If it is heard, it is of equal intensity of A2 and P2.
Okay. If the P2, even in pulmonary area, normally A2 is louder than P2. If P2 is equal to A2 in pulmonary area, you can say it's a mild pulmonary artery hypertension. If P2 is more than A2 in intensity at pulmonary area only, it is a moderate pulmonary hypertension. If P2 is banging in intensity and louder than A2, even at apex and other areas, it is severe pulmonary artery hypertension. So how is it here?
Sir, here it is heard at the apex, sir, and it is palpable.
The question is about the relative intensity.
Yes,
so it is more than A2 even at apex.
Yes.
Okay.
Sir, there is an systolic murmur which is heard at the what?
This is not the way to describe it. Please. Huh?
There is a pansystolic murmur which was heard at the left fourth intercostal space.
So there are a lot of adjectives you have to add before saying pansystolic about its pitch, its intensity, its grade, and all that should have been described before saying pansystolic murmur. Okay. Now again repeat.
Pansystolic murmur of with a high pitch murmur, which is heard at the left fourth intercostal space, which is more heard on the deep inspiration, and it's of a grade 3/6 murmur.
It's a common trap that everybody falls into. Suppose if you are looking for an inspirator, would you ask the patient to do deep inspiration?
No, normal inspiration.
Why are you saying that this is more heard on deep inspiration? But why are you doing it in AR? AR is the one situation that we always use it to do in end expiration, ask the patient to help the breath in end expiration. Rest of all the movements are always in normal breathing. Rest of all the variation that we look at is normal breathing. Why we do it in that fashion in AR? That is the only situation that we ask them to do help the breath in expiration and then ask them. Why do we do that? There are two reasons for that. Generally, the AR murmur, the frequency and the pitch of the murmur and the character of the murmur correlates with the respiratory sounds. You can get confused. And then while doing that, you remove the lobe of the lung that comes between your chest wall and the heart. So you just remove it while breathing in. That's why we do that. Rest of all is normal respiration. Never changes in deep inspiration with that.
So is this increasing on inspiration?
Yes.
Okay. So high pitched pansystole murmur occurring at left lower sternal border, increasing on inspiration. Okay. Anything else on auscultation?
Sir, one additional sound I can heard, sir. It is of a additional hard clicks type sound because I can't.
No. Yeah,
Which click, pulmonary injection click, ionic injection click.
Actually,
sir, let him say. You are giving all the clues. That is very generous. Tell me, what is that additional sound? No, whatever you feel, please fearlessly say this.
sir, I've heard an additional sound after S2, which is of a vascular type of pulmonary hypertension click
Where?
in the second and
No,
third.
in cardiac cycle, where is it occurring?
Sir, after sir,
Hmm.
after S1,
After S1.
yes.
So you say is it constant or inconstant?
Sir, it's in inconstant click, sir.
Inconstant click, ejection
Sir,
click,
sorry,
ejection
sir,
click.
sorry. It's a non-phasic click, sir. I mean, sorry, it's a
No,
constant.
the only way you describe a click is whether it is constant or inconstant. Is it, don't use that non-phasic, etc. So it is an inconstant click or constant click?
Constant click.
Constant ejection click.
Yes.
You have heard. Good, very good. Okay. Anything else? Is there any Graham steel murmur? You should look for that. Yeah. RVOT murmur is there?
Couldn't appreciate.
Couldn't appreciate.
What is the diagnosis? Other systems are normal.
Yes, sir. Other systems.
Give a systematic diagnosis.
Sir, this is of a congenital heart disease. With sir.
Cyanotic or acyanotic?
Congenital heart disease.
Hmm?
Cyanotic congenital heart disease. This is of a probably of atrial septal defect with of a predominantly.
Before that, you should say the broad group. Is it Eisenmenger syndrome or not?
Then Eisenmenger is
So tell Eisenmenger syndrome. Then you say where is the level of the shunt, right to left shunt.
Right. With PA. With suppress.
So cyanotic congenital heart disease, Eisenmenger syndrome, ASD. Okay. Then continue. Is there right heart failure? No.
It's a class 2 symptoms as of now.
Is there right heart failure?
No, sir. No predominant congestive cardiac failure.
We should not be asking this.
So no congestive cardiac failure symptoms were there, sir. And there is no, sir, rhythm was sinus rhythm with no any
No evidence of infective endocarditis.
endocarditis or embolic manifestation.
Not substantiate each component of your diagnosis from your own examination finding.
So first of all, it is often a patient is having a congenital heart disease, which is probable first diagnosed is in the point of like the patient was apparent of didn't have any symptoms from the last of her life. Presentation was of a.
No, it's very simple. No, patient has desaturation and some cyanosis. So it's a cyanotic congenital heart disease. Okay, then why do you say it is a right to left shunt across ASD? Why is it not something else? VSD Eisenmenger or PD Eisenmenger?
The P2, before that, sir, it is a decreased QP ratio. Decreased QP. And the things were favoring of ASD is a wide fixed split. FFA, the thing is to be VSD, it would be a single. And the second is point is sir, cardiomegaly is not very sure of this. The age of the patient is of 40 years. It is of ASD with Eisenmenger most. What about DR? Sir, ASD is more like 8 to have PR.
But in other words, how do you diagnose PH in ASD?
Sir?
Leave alone this patient. How do you diagnose PH in ASD?
The split which will be wide variable, now it will be in wide fixed.
If you keep on after telling every 3 months, 6 months, note it down, then you can say that. But otherwise, it will remain wide and fixed.
Sir, the cardiomegaly which will be regress. No, cardiomegaly will be appreciated in ASD.
No, before pulmonary arterial hypertension develops, is it a wide variable split in ASD?
Yes, sir.
No,
No, sir.
What is it?
that is why it's a
White
It's always wide fixed speed. That is the
white-
pathognomonic clinical sign, whether it is PAH or no PAH.
So how do you diagnose PH in health?
So the desaturation level,
So one is desaturation. If there is desaturation, then it could be there. Is P2 loud in ASD alone can happen without the pH?
yes, sir, it can happen. So the
Can P2 be palpable in ASD without the pH?
yes, sir, it can.
Can the left parasternal be there in ASD without pH?
Yes, sir, volume over.
So what you have to understand is all these signs of pH can be there in isolated ASD with large flow also. What will be missing is either patient is cynosed, then you can think of Eisenmenger, or if the patient has all the features of a large ASD with large tank, but doesn't have a flow murmur. It doesn't have an RBS. That means all this is happening because of PA pressure rather than increased PA pressure rather than increased flow. So all these things happen because of two reasons can happen in ASD. If the flow is very large, then you can have parasol heat, you can have a loud murmur at the base of the heart, and you can have a palpable flow. All those things can be there. But if it is flow, because of flow, you should get an RBS3, you should get a good murmur there, MDM there. If you're not getting them in the presence of RBS3, a large heart, a large ASD, then you should think of PH. So PH diagnosis is difficult in ASD, but in this case, you have obviously cyanosis.
So is PAH is due to two reasons. One is PAH related to flow, as far as been telling. The other one is PAH due to elevation of the pulmonary vascular resistance. The PAH is due to large flow, as he already told. There will be RVS3 and a tricuspid flow rumble, tricuspid MDM, and an RVOT flow murmur also, ejection systolic murmur. When PAH is due to increase in pulmonary vascular resistance, flow will be curtailed. So these symptoms of large flow, these fine signs of large flow like RVS3, tricuspid MDM, and RVOT murmur will disappear. So that's how so PAH can occur with flow itself. So that is a reversible situation. You can close it either by device or by surgery. But when the patient develops pulmonary PAH due to raised PVR, you have to look for the operability. Okay, now what is the incidence of Eisenmengerization in ASD depending upon the age?
Sir, followed series it is of more than 35 years, the Eisenmenger, and
More than 35 years?
Eisenmengerization, Eisenmenger syndrome will manifest of ASD.
No, that is, I'm not saying what is the mean age at which ASD Eisenmenger is clinically diagnosed. That's what Paul would says. That's not the occurrence. Occurrence usually in the adult age only. But first decade of life, what is the incidence? Second decade of life, what is the incidence? After 40 years, what is the incidence?
So in first half of life, the ASD Eisenmenger will not be able to isolated ASD until unless association with on
So it's very less than, so so there is EMC series by Cherian et al. So in first decade, it is about 6%. Second decade, it is about 7% only. And after 40 years, there is a sharp increase in incidence of pulmonary arterial hypertension, atrial arrhythmias, etc. Okay. So it will be those who are destined to become Eisenmenger ASD, 90% of them will develop Eisenmengerization in adult life, like fourth decade. Okay. Same findings, cyanosis, let us say patient had cyanosis and clubbing with clinical findings of ASD, like a wide split second sound.
Could be common atrium condition or coronary sinus defect. This will be early unrouged coronary sinus and rare case of TAP.
But what is the future in the TAP that you are not getting?
Sir, increased flow conditions
So
of
like that will be find RBS3, MDM, flow murmur at the pulmonary. All those things will be there in the
Now just tell me all the causes of cyanosis associated with clinical features of ASD.
Sir,
Not in this age, right from the neonatal or infancy to adult age.
Sir, ASD with TR could be the and eustachian.
Why ASD is TR?
So the jet which is related to TPFO.
That's the last thing I should say. What are the other previously you have to say? Like, for example, one most important thing is ASD with PS or ASD with PA.
Yes.
So what are the other things that can be associated with cyanosis?
Sir, the IVC blood which is directing the
Yeah,
eustachian valve. to
yeah,
form.
yeah.
What is the
Good.
bonus?
Sir?
What is the condition which they present with? What the ortho, something, some syndrome is there. How do they present in cyanosis? What is the typical feature of cyanosis?
Sir, reverse differential cyanosis.
Not reverse.
No,
What is the orthodeoxia? Platypnea.
sir, platypnea orthosis. Yes.
That's one. Then what else?
So transient neonatal cyanosis of infants or newborn with ASD. So because of high PVR, there can be right to left shunt across the ASD, and that will cause that. Then orthodeoxia platypnea, then Eisenmenger.
This is large. Question is asked. We have Andrews
Ragib syndrome. Huh?
Or
Okay.
you can have Epstein's anomaly.
Epstein's anomaly.
Or RV hypoplasia, because there could be RV problems can be there that can produce stunting. And then you can have sometimes the eustachian valve directing the flow that you already uncommoned.
And then ASD is a part of a complex congenital heart disease like tricuspid atresia. Okay, like that. So at least 10 causes you have to learn TAPVC.
And finish with the diagnosis. What is the echo wise? Just pain.
Sir, one possibility is of the what it could be the RV ischemia could be which is
Echo finding.
Okay, echo diagnosis, please.
The echo says titus solidus, levocardia, 2 atria, 2 ventricles, intact ventricular septum, large ostium segment AV with bidirectional shunt, with moderate ER with severe PH, mean PA pressure of 50. So,
so one last question. When you have clinically auscultable TR murmur and echo also showing significant TR, why is your JVP normal? Why VVAV is at least not equal to A, if not more?
because of the roomy RA which is.
See, your JVP examination, I think, is not very accurate.
what do you want to do for
Sir, operability
Want to
cats.
test for upper?
Yes,
Want
sir.
to do a cardiac?
Yes, sir.
Why somebody is 80 saturated? Why you want to test for operability?
See, at rest, it is 88%.
With 88%, there is no way you should be doing standard or some other cause of cyanosis that we discussed. But because of PA pressure 88, I don't think you should be taken. Well, how do you want to treat it?
Sir, the pH reduction, there is a calcium channel blockers. With
Calcium
no,
channel
sir. Like endothelial is a prosentan and direct
Which one will you prefer, combination therapy or single therapy?
combination therapy.
Why? Why combination Eisenmenger syndrome? What is the evidence for combination therapy in Eisenmenger syndrome? What is the evidence for combination therapy in IPA? Right. तुम लोग तो बहुत ambitious रहते हो. Ambition trial. So such trials are not available in Eisenmenger syndrome. So some of the combination studies were negative. So you may not start in everybody with combination. So which drug will you prefer?
Phosphodiesterase 5 inhibitors.
Maybe bosentan has most evidence, so people generally prefer bosentan in Eisenmenger, but you can use any of them. Either two of, if the patient is sick, then you can try combination. Otherwise, you can start with ERAs and then add PG.
I think we'll stop. Okay, then, thank you. They have done very well. Give them a big hand.